Hey everybody, how is everybody doing? Sorry, I just had a couple things I had to do. Had to get up and close the door. Um, Welcome to my live. This is my first time going live. This is something new for me. I have never gone live before on YouTube, and I've done lives ton on TikTok. I'm gonna figure out how to do live on Instagram as well. If you're not already subscribing to me, make sure that you are subscribing to my channel here. I appreciate that. And if you want to be on my email list, you can join my email list by going to my website, nurseadrian.rn.com, and you can get on my mailing list, or you can go to my link tree, and it's super easy there. I think there's something that says join my tribe. So go there, check it out. I've got my nurseadrian.com website all up, and I was actually trying to figure out how to flip this around, but I guess I don't know how. So I wanted to talk to you guys a little bit today about patient advocacy. This is a topic that most people don't know too much about. Many of us are finding there are a little over 1,000 of us who are board certified as patient advocates, and we are a growing number of people. I'm going to pull up some information here. I haven't figured out all the tricks of how to pull up information because I'm not on StreamYard, but I wanted to share with you the different types of patient advocates that there are. And patient advocates don't have to be board certified. That is a really fairly recent phenomenon of the last few years. Hey, what's going on, Mr. Midwife? What's going on? Hey, and thanks for joining me on my live. We're going to see how long this lasts. I'm thinking about 30 minutes, so we'll see. Might go a little longer. So we are certified through a body. So it's called BCPA is the certification we hold, and it's Board Certified Patient Advocate. And it is a certification that is done via an exam. There's a fairly rigorous exam. If you're an RN, it's not as difficult. A lot of it is content that we already are familiar with. Well, hopefully many of us are familiar with, maybe not all, but it's ethics. A lot of ethics, some insurance information. It would take a review for anybody, I think, to pass the exam. But there is a very large ethics component to the board certification, which is really great. Yeah, I am exhausted. I got up at 4 o'clock this morning, so I was really debating on whether to do this live. Yeah, and I'm a little washed out. Sorry. Yeah, a little tired today, a little bit tired. And yeah, I got up very early, and I've got a long day because I had to take somebody to the train station very early. So yeah, a little bit tired today. I think you know what it is. I don't have the right lipstick on either. I think I got to put the right lips on maybe. Let's see if we can do that. I've got this muted color on, which is just further washing me out. The other thing is that I have an eye injury on this eye, my right eye, that is making my eye look a little bit different. But yeah, I had a shake bottle like fall on my eye, and I thought it was going to be okay. And I think maybe I need to go see a doctor. I mean, I'm usually like, oh, it'll just resolve, but I have this little floaty thing going on that um, it's getting kind of better. But I'm a nurse, so I'll wait till I'm like dying or going blind in my eye to go see a doctor. So, yeah. So the Patient Advocate Certification Board, it's just a kind of rearranging of the board certified patient advocate. They're the ones who certify us to be patient advocates. And as such, we are part of a couple national registries. If you go to Greater National Advocates, GNA, they have all of us listed who have applied to be listed there for free. Greater National Advocates is a nonprofit, amazing organization started by a lawyer, Bradley Schwartz, who actually lost all of his limbs as a result of sepsis that went undetected while he was in the hospital for something. I don't recall what he was in the hospital for, but it wasn't related to being septic. Let me put it this way. So he ended up losing parts, all of his limbs um, in that process, and came out of the hospital, is an amazing person, has, learned obviously to adapt after years of this, and started Greater National Advocates because he understood very clearly how having an advocate would have made a huge difference for him. I wonder if my lighting, I could also, I'm getting a little washed out there. That's a little bit better. So I just want to talk about that a little bit. And there are people, when I came out of, I did this exam in 2019, and I started my business last year. And I thought many people, or most advocates, would be nurses, and it turns out they're not. There's a few of us that are nurses, quite a few that have, I would say, more successful businesses doing direct patient advocacy are nurses. But there's a whole sector of people who do this work who are also very well versed in the insurance industry, which that's not necessarily my wheelhouse. I do a little bit of work in insurance claims, but not entirely. So some people pretty much build their practice around insurance claims. And so there are now more or less some subspecialties of patient advocacy. And so, why is this important? Well, think about the last time you were in the hospital, your loved one was in the hospital. Yeah, can I explain? Yeah, I know it is a very, yeah, I'm going to explain this. So basically what we do as patient advocates, so we are privately hired. There are a couple organizations. I do have some colleagues who have started nonprofits, parallel with their businesses, to raise money so that they are able to then provide subsidized patient advocacy or free patient advocacy. So if you're in the VA system, you might be familiar with that term. If you've had a child with a disease or illness, oftentimes there are patient advocates that are internal to a hospital system, or you may have a patient advocate with a certain type of illness related foundation per se. So what we do is let me tell you what I do, because I don't do the insurance. So that's not my wheelhouse. It's an adjunct to what I do. But then if there's something beyond my scope, then I have people that I can reach out to who are very, very experienced in dealing with insurance claims. So people will hire me. It's usually a retainer basis. So you have to think of it in terms of almost hiring a lawyer. And it can be a short-term investment, it can be a long-term investment, depending on the need and what's going on, whether this is an acute illness, whether it is something that, maybe more of not, we don't really deal with emergencies per se, because there are forms to fill out. There's a process of onboarding. And so this is why it's important to kind of get ahead and think ahead into the future of what you may need, or what a family member may need upon maybe an initial diagnosis, and then the prognosis of perhaps a chronic illness. Now, if it's an acute illness, that's a bit different. So maybe a short-term stay, maybe, something that somebody's dealing with for a year or maybe a few months. It could be just something for, a few weeks that they're dealing with, a surgery and then a recovery. Now, if somebody is planning a scheduled surgery or scheduled procedure and they want to hire a patient advocate, that's perfectly fine on the short term. We do all different services. So, typically we do an intake. So we do I would do a full assessment. I would ask the person, individual, okay, do you have your advance directive? Do you have your healthcare proxy? Do you have a list of all your medications, all the prescribing doctors for your medications? So there's a bit of a background assessment that's done. And as nurses, we naturally are assessing, right? And if you've worked in a hospital as a nurse, a lot of these are questions that we ask patients every time we do an admission assessment on them. And it's the same process basically coming on board for service with me, because I want to make sure that you have just the basics done, so that then we can figure out, okay, where do we need to start? Like, how prepared are you as a patient to be interacting with the healthcare system, right? So advanced directive, healthcare proxy, medication list, making sure that you understand. I want to know, what is your knowledge base of why you're taking your medications? What kind of diagnosis have you been given by doctors? Is it you have arthritis, multiple sclerosis, degenerative disc disease? It could be something that's just, rather benign, to something a little bit more, acute, that's going to need more care. And to make sure that you understand, and I understand what your understanding is of why you're taking medications, And do you understand what these diagnoses are? What have you learned about these diagnoses? Have you had them verified by a second provider? How long ago were you diagnosed, etc.? And then a full list of all your physicians with the last date that you actually saw these doctors. And then what we want to know is, this is something very important for people that are on a lot of medications, is who's in charge of your medications? Who's the doctor, provider, nurse practitioner who is going to be reconciling what we call medication reconciliation? So who's going to look at the big picture of all the medications the cardiologist has prescribed, the kidney doctor, maybe a neurologist, a general practitioner, maybe a GI doctor? Who's going to make sure that everything is aligned and there are no interactions going on? Or perhaps you don't need a certain medication anymore, or maybe there's a different medication that will suit you better. So again, a lot of people just keep adding on and adding on to their medications rather than actually having their physician sitting down, making that appointment, saying, I just want to have an appointment so I can just go through my medications, and that's all we're going to do. Let's make an appointment so we can go through all my diagnosis, and that's all I want to do, right? And then this is very, very important because perhaps something was misdiagnosed. Maybe it's already been resolved. Maybe it's turned into something different. It's hard to say. So you go between me, the patient, hospital CEO, insurance company, other physician, basically everybody, right? So we are I would say the not the referee. We are, working for the patient, and what we're doing is we're going in. So then once we do this full assessment, I meet with the patient. Okay, what are your expectations? What are you struggling with in the healthcare field? And it could be also something like the other area where people will hire us often is if they are geographically distant from the person for whom they are responsible to make decisions. So as we know, many of us are not living near our families. People are taking jobs across country. They move for various reasons, military. People move out of the country, but they may still have their mothers, fathers, aunts, uncles, children, whoever, in another country, 3,000 miles away, 5,000 miles away. They could also have a job where they are extremely busy and not able just to drop everything and go be with somebody at a hospital. That was my situation. So, and if I could have hired me 20 years ago, I would have been in a really different place in my career at that time, my chosen career in my 30s. If I didn't have to keep dropping everything I was doing, getting on a plane, finding somebody to take my place, doing some operational work that I was doing with the unions I was working for and the campaigns I was on. So imagine, you're running a company, you're the CEO, you're the president. Maybe you've just got 6 kids, 5 kids. Maybe you've got your own issues going on. And then, your aunt, who maybe you don't even know that well, is having health issues, but you're the only, you're the designated person to make decisions. But then you don't even have the bandwidth, nor do you have even maybe the desire. You care about this person, but you know that you're not the best person to actually be making an assessment and making decisions, or you need some help with some recommendations or information or clarification. Or maybe you need somebody to, go see Aunt Sally in Vermont and just make sure, hey, is she okay in that skilled nursing facility? Can you just check in on her and visit her once a month? So some of the things that I do mostly remote work. I don't do a lot of actual sitting in the ER with people or sitting at the bedside with them, although that's also negotiable in the services. But it could be a situation of people that are in a long-term care situation, whether it is psychiatric care, it could be any long-term for a physical illness, disability. They're just not able to take care of themselves, and they could be all various mental states. So it's not, I'm not a proxy for anybody making decisions, but I will go in there and just check in and talk to the doctors, talk to the nurses. I get access to their records if that's what the patients want to allow me to do. So I have access to their medical records. And even if somebody wants a full chart review, I have nurse practitioners and physicians who can also do that as well. I don't do that. I don't do anything nursing per se related. as far as direct care. So hopefully that makes sense. So that's more or less, like, for example, I may, get hired by somebody and they've got upcoming doctor's appointments. So we'll schedule the appointments. They'll send me a form, we'll do some forms back and forth, and I'll releasing medical information, and then I'll send these forms off to their providers. And in that sending the form, I'll include a letter introducing who I am. So it's not an adversarial relationship. It's really important that providers understand, hey, this is a bonus kind of for everybody, because a lot, everybody's squeezed for time. Providers don't have enough time, that they often want to, educate their patients, or maybe they don't have the staff to do it. Or just there's things going on. Maybe they've got an emergency that they have to attend to, and they've got to make a particular visit rather short for a patient. So I can be there on my iPad with that patient remotely on FaceTime, and I make it very clear to the providers, this is, where I will be involved. I'll either be in person with this individual with their appointments, or I'll be on FaceTime, and I may or may not be recording the entire appointment. And recording an appointment can be very helpful, because later that can be used for the patient so that they can go back and listen to that or watch the appointment and understand, okay, yeah, this is what the doctor said. Because oftentimes people go to the doctor, right? And we've all done it. Who hasn't done it? I have. I've gone to the doctor, gone to a nurse practitioner, and either I have done everything I could to remember everything I wanted to tell them, right? Especially if you have to change providers. I recently had to change providers, so it was just like, oh man, like where do you start? And as you get older, you got more to tell, more history, and then so you're trying to bring information to them, hoping you've got everything you need, but maybe there's just not enough time, and you have to do maybe a couple visits to get everything, the information exchange done. And at the same time, they're giving you information that you probably are going to forget about 70% of. I mean, I don't know. I haven't seen actual research on this, but I would be really curious to know what the retention rate is, for people that, and you guys let me know when you watch this later, when you've gone to a doctor's appointment, or even when you've gone with a family member, how much did you remember? Has not everybody been in that situation where we're thinking, okay, what did the doctor say? What was that medication they may put me on? Or what were they going to check for? You go do labs, you may look at the lab sheet, or maybe you don't have a lab sheet, everything's electronic. It's just a lot of information going on. And because we're also under stress, we're having a stress response in our brain, especially if we're going in and we're not feeling good, then that also interferes with memory and retention. The more I talk, the more my patients' eyes glaze over. Right, right, because they got so much on their mind. And then what is the average attention span anyways, right? It's just, and even in your situation, right, Mr. Woodwife, I mean, this is like, people are like, yeah, like they're having a baby. I think visuals are really good. I'm still actually really surprised that in doctors' offices, they don't employ more visuals in provider offices. I'm so visual, I'm like, can you just put a chart up and just bullet point it? And then I will probably remember more off of, even if it's on a dry erase board, than if it's in my hand. And yet we give patients a lot of information now. We give people printouts when they leave a doctor's visit, provider visit. But what is on there? Okay, it's got your vital signs, your weight, your diagnosis. And then it's got just a bunch of gibberish, right? Some legal mumbo jumbo. These EHRs like just crank out trees, but are they really giving information to patients? I don't think they are. I really don't. You know, um, I think that with less paper and more concise information, um, and also a means by which patients can get more information. Now, we covered this on another episode, um, where I don't know, did we cover this on Liz's show or not? I don't know. Maybe we didn't. I did a short video about it, about being charged for messages. And I think a lot of providers thought I was coming down on them. I'm absolutely not. I think it's totally appropriate to charge. But it's just people aren't aware. They get these portals, so you're on your phone, you're like boom, 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 boom. You're, looking up your medical record, And then it gives you an option. Do you want to reach out to your provider? Do you have a question? Oh, sure. Yeah, I have a question. Okay, great. But they're not telling people that they're charging them for these messages or that they can charge them. And I don't even know what the legality is on the retroactivity of all of that. Sorry, I need to put some WD-40 on my chair, which I totally forgot before I started this. So I'm just going to stay very, very still. So that's a little bit about what I do as a patient advocate. Not all patient advocates are board certified. Again, this is a very recent, I took the exam, I think it was 2019. Yeah, so I just did my first renewal last year. We have to do a lot of continuing education every 3 years to maintain the certification. And none of those hours overlap with my nursing continuing education requirements. So I did 32 hours. It's more than required for my RN. I do 24 every 2 years for California. And I don't know what I do for my state that I'm in now, actually, because I don't have to, but I better check. I'm probably due for a renewal pretty soon. So on that, then there's also a lot of other organizations that have arisen that help people find resources. There's Greater National Advocates. There is Pulse, Center for Patient Safety and Education. I would definitely check out Pulse. That's a great nonprofit. Tons of free information there. A lot of downloadables. If you're interested, though, in actually hiring a private patient advocate, you can go to my website and get on my email list. So let's talk about why some situations, if we can think about in the news, why or when you may need a patient advocate, right? Besides the fact that we've discovered there's, maybe definitely thousands of fake nurses who somehow have, acquired credentials practicing around the country. They're gradually being rounded up. I should keep a count of all of them, but there have been pockets of them. The Veterans Affairs is doing a big purge. They have brought back many of their staff as consultants to review the files of new hires. But imagine, just look in the news. What are we seeing about nursing homes, long-term care? And long-term care has really changed so much. And there's there's acute long-term care, skilled nursing facilities, rehabilitation facilities. There's all this confusing nomenclature that even I struggle to understand because I worked in acute care. My mother lived in a nursing home for the last 9 years of her life. So I'm very well aware of skilled nursing facilities and some of the issues that can arise. And I was very vigilant to ensure that my mother received the best care possible. But even then, because I was out of town, I was out of the state at the very end of her life, an illness, her having pneumonia, was not addressed. And that, led to her demise eventually. So let's talk about something that came up in the news today. So I'm pulling it up on ABC. So in Iowa, this was a couple days ago, so I don't know how I managed to miss this piece of news that is very disturbing, right? So employees at an Iowa medical care center, so they're saying medical care center, because some of these skilled nursing facilities can pretty much operate like a med surg floor in a hospital where patients are still getting IVs, they're getting treatments. And then there's staff like one nurse to 47 patients, maybe 28 if you're lucky for one LVN. That's not even an RN. So, there's a lot of issues here. So I'm going to read this. Employees at an Iowa medical care center mistakenly deemed a 66-year-old woman in hospice care as deceased and coordinated her transportation they say in a cloth bag to a funeral home, right? Because they're not going to say a body bag. So this is from the Iowa Department of Inspection and Appeals. So if you live in Iowa, apparently the Iowa Department of Inspection and Appeals, maybe that's their version of the Department of Health. I don't know, or if they're some kind of investigative body. So they noted that this woman was in hospice, and she was 66 years old, I believe, with, let me see, I think it was dementia. Yeah. The resident suffering from dementia, anxiety, and depression So we're not putting anybody in hospice for anxiety and depression. Dementia, yes, because that could be very degenerative. So she came to the facility in December 2021. She was transferred into hospice on December 28th, 2022, because of senile degeneration of the brain. There, staff began administering morphine and alprazolam, also known as Xanax, right? So morphine and Xanax. So basically, this woman's on comfort care of some kind, hospice. They're making her comfortable, giving her doses of morphine and Xanax. Now, both of those drugs can do what's called depress the breathing system, right? Right. Maybe verify that your patient is actually dead before you send them to the morgue. I mean, yeah, it was okay. Yeah. So this is kind of. Here's a question that I never thought to ask. I mean, I'm amassing this list of questions to ask as a patient. Apparently, we now have to ask, how will you verify if a person is deceased? How will you be verifying that they are no longer alive? And I'm not gonna, I'm not gonna make any leaps here of judgment. However, I don't, I know what we do in the hospital. I know, there's different, there's different processes in place, but this is very important. So if you are placing or having to go into any kind of facility, right? It could be a senior living facility that has different levels of care. And this is a really actually an important question. Are you allowed to pronounce death? Are you allowed to pronounce death? And what is the process that you will use to pronounce death? I mean, so the patient appeared comfortable and calm on December 29th. However, she began not coming out of her room for meals. So apparently, if she's not coming out of her room for meals, but she's on hospice, they're making it seem like she was able to walk and ambulate, which maybe she was. Okay, so maybe she was, maybe she wasn't, or maybe she was refusing to come out of her room for meals. She refused food on December 30th. Hospice staff eventually noted a decline in temperature and that she did not open her eyes and did not speak or respond on January 1st. This is so now this is where it gets really interesting, and now where I'm getting suspicious, right? Basically, cessation of vital signs. Right. But is it so? According to this, this is what they assessed. But in some cases, like I know in our hospital I worked at, the main hospital I worked at, one option for declaring if somebody was deceased was actually an EEG, which of course never gets done. I've never seen that one time. No, actually one time we did. But again, that was at a time when we didn't even have EEG techs 24/7. So how are you going to determine this? So December 29th, she's not coming out of her room. December 30th, she refused food. Hospice staff, now I don't know if this is separate hospice staff or this is staff inside the care facility. Again, this is not really clear. A decline in temperature, okay. And that she did not open her eyes, did not speak or respond on January 1st. And on January 2nd, she began to suffer multiple minor seizures. Now, this is very interesting. So I would love for anybody to weigh in on this. So, because she's on Xanax, alprazolam, typically we'll give benzos if somebody's having a seizure. On January 3rd, after a 12-hour shift, a staff member reported she did not feel a pulse and the resident was not breathing at that time. According to the report, a licensed practical nurse assessed the woman's condition for 5 minutes, then felt the resident had passed away. Okay, at roughly 6 a.m. So this is on night shift, somewhere around night shift. They're saying after a 12-hour shift, a staff member reported, but they're saying that the LPN assessed the woman's condition for 5 minutes, then felt the resident had passed away at roughly 6 a.m. She then called the family and on-call hospice nurse who called the funeral home. The report later noted that the resident did not have a do not resuscitate order. Yeah, if you're on hospice, you are a DNR. I don't think there's any other way to do it. At 7:38, this is about 90 minutes later, the funeral director arrived, placed the woman on the gurney, inside a cloth bag and zipped it shut, according to the report. The funeral. So, are we using cloth bags? First off, are we using cloth bags? That's just kind of weird and icky. I've never seen a cloth bag for somebody who's deceased. They usually are some kind of plastic, um, like waterproof kind of material for a very good reason. The funeral director also reported no signs of life. Are they able to assess that? Is that something? I mean, of course they'd have to, So then at 8:26, about an hour later, the funeral home staff unzipped the bag. So, they bring her to the funeral home, however much time that took, the drive there. I mean, I just hope that they handled her with care. Um, Unzipped the bag, witnessed her chest movement, and gasped for air, then called 911. So I think they're stressing that there's a cloth bag here, and I think this is for a lawsuit. I think we're going to find out it's not a cloth bag. So that's my thought. Outside the scope, right? So typically an LP, does an LPN ever? Do they ever do that? Reusable? Are you kidding me? Reusable? Who washes them? What? Okay, that's just weird. That's weird, Mr. Midwife. I don't know. I don't know. Okay. The woman passed away at the facility. Okay, so she was returned to the hospice the same day. So she was taken back, not to a hospital, but she was taken, and this is kind of strange, but maybe that's the protocol, that, she was taken to the hospice the same day, continued hospice care around the clock. The woman passed away at the facility with hospice and her family at her side 2 days later. So she lived 2 more days. She had these seizures, right? So this is why the story, it was kind of took place over several days, right? Yeah, you have to be at least an RN, right? So we already have some problems here. So we already know we are in trouble. So just when I thought, so what, today is the 6th, right? Okay, that story came out about, there's some that came out so 3 days ago. So while I was researching this story, turns out the lady in Iowa is not alone. It turns out, and again, this is why it's important now. Would a patient advocate have been able to prevent that from happening? Absolutely not, because we're not there 24/7. That's if you want to hire caregivers 24/7, and you can hire private caregivers round the clock or for whatever hours you want when a family member is in a facility, in addition to the care that they get. I used to do that. I took care of the wealthiest people in America when I was in nursing school, and I learned quite a bit from that experience for 2 years doing that work. And that even in places that were outrageously expensive, I'm saying $30,000 a month, $40,000 a month, and then or the staff that I worked with were being, paid, or the agency was being paid somewhere, maybe $20,000, $15,000 to $20,000 a month to provide care in addition to the basic care that was given at these really high-end facilities. There's a lot to be desired. Money is not, it's very important to put your money in the right place, let me tell you. Because regardless, the attitudes and the staffing might be a little bit better, but as far as the actual care, it's not. It just isn't. So check this out. So now we go on to New York. So it turns out in New York, there's a funeral home. The headline's great, right? So New York funeral home finds woman breathing hours after she was declared dead, just days after a similar incident in Iowa. And you guys, if you haven't, you're watching this later, do me a favor, subscribe. I really appreciate it. And come back, watch this, give me some comments, and let me know what you think about this and these stories, and about whether you would hire a patient advocate, and really think about the investment that could be. So an 82-year-old woman was pronounced dead at a New York nursing home, but found to be breathing. 3 hours later, at the funeral home where she had been taken. Well, we're kind of losing, let's just face it, a lot of us have lost a lot of confidence in New York, period, right? Now this is in Long Island. And I have some friends in Long Island that are patient advocates, so I'm very interested to talk to them about this. Because this is, Long Island's a big area, but it's also a small town, more or less, if people have lived there a long time. So the woman was pronounced dead at Water's Edge Rehab and Nursing Center at Port Jefferson on Long Island Saturday. The woman, whose name was not released, that's fine, we don't need to know her name, rest in peace, was taken to the O.B. Davis Funeral Homes in Miller Place at 1:30. Police said in a news briefing she was discovered breathing at 2:09 p.m. So, okay, that's already not making sense. She was She was pronounced at 11:15, and then at 2:09 they discovered her breathing. All right, so the woman was taken to a hospital. No update on her condition. Okay, so this woman, we don't know if she's deceased, still alive. The case has been referred to the state attorney's general office for investigation, which is exactly where it should be referred to in Iowa. Iowans, come on, make some noise in Iowa. Get your state Department of Health, your attorney general, all of these boards, these state licensing boards, nursing boards, find out who licenses and licensed practical nurses. It's often not the same body that licenses RNs. Get after these boards because they often report directly to the governor's office. The state, that's kind of a bypass of any of your state legislators. Often your state legislators don't have a whole lot of oversight or direct relationship with these boards other than when it comes to budgeting. But definitely also reach out to your state legislators because this is something that we've got. This is deplorable. No confidence in New York. The state health department is investigating as well. Spokesperson Monica Pomeroy, she cannot elaborate. A person who, so they hung up on somebody who called. They can't. They're saying they can't comment further on this matter because their asses are getting sued. Right? The apparent premature declaration of death occurred days after a continuing care home in Iowa was fined $10,000. So this is kind of interesting. So I forgot to tell you guys. So the Iowa situation, somehow, like overnight, they got a fine of $10,000. So it was a very quick process where they decided that they were going to fine this facility $10,000. Now, I don't know who owns this facility. A lot of these facilities are owned by hedge fund companies, multinational corporations, or they're privately owned, and the owners have multiple facilities. We talk about, seeing the owners roll up in Rolls Royces and, really nice fancy cars and, but you go in and there's not enough towels and the food is crap, right? So a fine of $10,000 is not adequate. That is not adequate. There needs to be action on that LPN. There needs to be action and investigation minimally on the staffing of that facility. And just fines are not enough. They're not enough of a consequence. These owners need to be put on probation for operating. And the reason they don't get a heavier, penalty is because there's nowhere to put these patients. This is the really sad truth. If you close these facilities, there's nowhere to put these patients. There's nowhere to house them. It's not like the state has some facilities where they can just, we're going to just pop these people over here and put them in this facility. They don't exist. Hey, Scott, what's going on? How are you? Thanks for coming by, you guys. Super appreciate my first live where I'm completely washed out and exhausted, but I thought, what the heck? I'm going to just go live and do a little practice. Now, what it doesn't say on the New York case, so this was a funeral home and crematory, where apparently they do it all in one. This is happening more often, right? So Scott, we're talking about people being pronounced and in a nursing home facilities mostly, and then taken to a funeral home, and then, they're breathing. Somebody's breathing in the bag. And Mr. Midwife has verified that they do use cloth bags. I was like, isn't that really dirty and gross and weird? I don't know. Because there's all kinds of body fluids that come out when people pass. I mean, that's another thing also. Although if somebody is really dehydrated, maybe they're not going to have so many body fluids when they pass, but it is very typical. It is very typical. So yeah, so it is interesting that this woman passed. Okay, this is Sorry, I was saying February, January 5th. So it's been a month, and they assessed a fine in the Iowa situation. It's just not enough. It's not adequate at all. How many live people have they wheeled into? I know everybody is thinking the same thing. We are all thinking the same thing. Oh my God. And I mean, so again, we're talking about this is something important. We're talking about patient advocacy, but it is important. We don't want to ask this, but look, none of us are getting out alive on this like flying rock through space, right? So if you are going into a skilled nursing facility or long-term care housing or senior housing, and maybe they have a lot of them, look, the hotel industry's gotten into this industry huge. So they have, you can go, you have your little apartment, little condo, and then when you can't, take care of yourself there, maybe you can hire somebody that you hire through them, that maybe checks on you, and then you can go into another kind of downgrade into a place that doesn't really have a kitchen. Then you get your meals somewhere else, or they'll bring your meals. They're all set up for like various stages, and these are all people if you have a lot of money and you're private paying. These are not Medicaid, Medicare funded facilities. But no matter what kind of facility, check and ask them, what is the process? If I were to pass, my family member were to pass, how are you going to determine? How will you determine that? Yeah, it's horrendous. Right. Scott is so sweet. His brain didn't go there. Sorry, Scott. Yeah. Yeah, not good news. So this is why you need a patient advocate. And so if you go to my website, I have a little bit of information there. I'm going to be starting a podcast also, doing more content about patient advocacy. Again, it could be an issue if you need a patient advocate for a week, you need somebody for a month, or maybe it's a undetermined but short period of time. Or maybe it is like, hey, my mom, or my dad, or both my parents, grandparents, whoever, are going into these facilities, or they just need help. They're at home. We want to make sure that they're independent, but we need somebody with, good eyes on them and checking, their medical care. What's your vibe on the doctor? What's your vibe on the provider? What do you think about, do they have the right equipment? So it's a combination of what maybe a home health nurse would do. And if you can get home health and get an assessment, like a safety assessment, that's great. They will also come in, and often Medicare will pay for that if you're under Medicare, for a safety assessment in your home. So those are additional things that we do. But a home health RN coming in to do that assessment is only going to spend max 1 hour, typically max 1 hour, because they have a lot of cases. They're getting paid, either per case or per hour, but there are caps. I used to do home health, and I loved opening cases because then I could really come in and assess the whole situation. My aunt, here's another, I want to tell you guys a story, right? So there are no protocols for determining death in nursing home. Maybe those need to be revisited. Right. I don't know. Right. I mean, it's like, are there any protocols? This is something that there are things that are coming out that we are realizing in this mega regulated world that there's no protocols for. And, this may be something that we need to start talking about more, or perhaps start putting our heads together on, with hospice nurses. And there are a lot of really huge hospice nurses on social media. I'm going to reach out to one of them who I follow quite frequently, and she does the on-call stuff. So she is pretty much the one who goes to these moments in somebody's home, more or less, but it could be in a skilled nursing facility. I just think that one, it can't be an LPN. So I don't know if you caught that, Scott, that it was an LPN who said they felt like the person in Iowa was gone. But I did read in another story that they were not able to assess an apical pulse, no blood pressure. I mean, you can have a completely faint heart rate. And I just want to say, if you're in a skilled nursing facility, those staff are not checking and listening to breath sounds and heart tones every shift as part of their assessment. That's not happening like it does in a hospital. So it takes training and regular practice to really listen to heart, tones, to beats, to murmurs, whatever's going on, to do any kind of assessment with a stethoscope. And so again, if you're only doing, it's like running a code. I realized when I worked very briefly in a rehab facility that was adjacent to my hospital, and I realized, they had a code they ran every 6 months or every 6 years. It was so rare they didn't know how to run a code, right? So again, if you're not in that environment where that type of assessment is happening, one, you got to have a couple pair of eyes and ears on the case, but not an LPN. It needs to be an RN. So where was the RN here? So I think we could have another case where an RN gets in trouble. We use vinyl, right? Oh yeah, right. I know, it's kind of weird. I'm like, cloth? What? Okay, that's weird. Do they get reused, rewashed? I don't know. I have so many questions about it. So yeah, so that would be a terrible way. Yes, it would be. I thought an RN needs to listen for heartbeat for 60 seconds or something. Right. It has to be an RN. I mean, so in a hospital, even the house supervisor who's an RN can pronounce with, with the doctor usually on the phone, or, they can do that. But I can tell you, having been present at the end of life for many a patient in inpatient side of the hospital, and Scott probably, as well, in his ER experience, that we get a couple people to check, because the last thing we want is to make a mistake. Because in a hospital, a morgue is in the basement, down the hallway, and God knows, I mean, even with COVID, how they were stacking, people up. It's just really like, it's a distasteful topic. So here I am having a really rough topic on my first live, but this is an important thing that we discuss. It's not the thing it's not a fun topic. Sorry, you guys, but I wanted to bring this up because I just happened to catch it in my search today, and I thought, this is really crazy. And I know, there's just, I have so many thoughts and feelings about it. It's unbelievable. So let's talk about patient advocacy a little bit more. So when I do an assessment on a patient, I'm going to typically, an assessment could be about $500 typically. And people are like, oh my God, $500. But we're talking about, it's usually going to be on site. It's going to be, the time. So think about when you hire a lawyer. A lawyer is going to charge you in 15 or 5-minute increments for their time. They're also going to charge you for travel time. So it's a little bit on that line. And so, if I have to go to another state to do an assessment, or I've got to drive 3 hours, that time is compensatable time, right? I'm running a business. So let's be clear about that. But there are some growing organizations out there, but again, we are very rare. It is again 1,000 of us in 50 states. I don't even know if we're in every state. So I know in my state there is maybe 3 of us for about a 200-mile radius, or maybe about 150-mile, 200-mile radius. Which where I live is about a 5-hour drive. So again, you're not going to find patient advocates just everywhere you are. And so part of that assessment is going to be multiple hours. It could be, anywhere from 2 to 3 to 4 or 5 hours. There will be work done in advance where I'll send clients forms, have them fill those forms out, do as much as they can in advance, because I want to be there. Or if I'm doing it remote with them, I want to be reviewing things with them so that we're not having to fill out. If I have to fill out the medication list, that's billable time, right? And that will be in addition to the assessment. So it's helpful if people have that information. If you go to the Pulse website, there are downloadable forms. The forms are there free. There's even a healthcare proxy form there free. So there's a lot of information on Pulse's site that's there for free. and tons of videos, educational information as well. But Pulse does not provide patient advocacy, nor do they answer any questions per se. So that is a resource site, and there are 3 meetings that we have a month. One is for patient caregivers. So it is very important that people have a proper assessment in this process of patient advocacy. And then I figure out, okay, here's, based on the need, is this person verbal? Are they able to verbalize their needs? Can they walk? What kind of living situation are they in? Who's taking care of them? What are their care needs? It could be people that are driving. I mean, people hire me that are fully, otherwise healthy. They just need help navigating the healthcare system because they can't remember crap when they go to the doctor, and they can't remember what the questions were. And they just want somebody who's there who could say, oh yeah, this is what the doctor said, the provider said, nurse practitioner said, this is, what they suggested you do, because a lot of information is getting thrown out. So that's a little bit of how it works. And then there's typically a retainer of a certain amount. And then I work off a retainer because it's just unpredictable the number of hours that I may be needed for each client per week or per month. It could be 10 hours one week. It could be no hours another couple weeks. And then I'm needed, for 2 or 3 hours on week 4. Also, in addition to individual patients, couples can hire me, families can hire us. So if you have a family situation, then you can also, if you've got 5 or 6 people in your family and you say, okay, you know what, maybe what we should just do is hire one advocate that's going to help us with, grandma, grandpa, auntie, uncle, us as we're aging, boomers are getting older, my generation's getting older, right? And, maybe there's 6 or 7 people in a family. That's really an ideal situation because then you're getting everybody on board and you're getting these conversations to start happening about decision making. Oh yeah, you get, Mr. Midwife. Yeah. So you pronounce, yeah, of course. You get a second, a third, and a fourth opinion. Absolutely. Absolutely. EKG spot check, right? Well, I was telling, I don't know if Scott, if you were there, if you're here, but we had some protocol, going back to pronouncing patients, that was to do an EEG, although I think maybe one time that happened. But again, we had this protocol, but we didn't have EEG techs like around the clock until we really built up the neuro program, that's all been fairly recent that neuro programs have been built up. So yeah, so it's kind of like, well, who's going to do an EEG? But EKG, exactly. You want to check, but then you can have no heartbeat. You can have brain activity that can be sensed, right? So this is something we need to talk about more. We need to have maybe an offline discussion about this. I don't know. They do right. Bedside ultrasound. There you go. Bedside ultrasound. Good one. Absolutely. 100%. Absolutely. I mean, they don't have a cardiac monitor. It's kind of like, they need to have some kind of telemetry system in every long-term care. But then again, if people aren't trained, it kind of like the resuscitation boxes. But I mean, if you hook somebody up, does it have a screen or does it just tell you shock? So maybe that wouldn't work, but some kind of system, because of course people aren't going to maintain training on that or be trained. Nurses and above, ICU nurses, ER nurses are trained to read telemetry. So yeah, so very different thing. So back to patient advocacy. AEDs don't show rhythm, right? Yeah, they don't. Yeah. Because I've seen like some older ones, I think, that used to, but yeah, they don't. They just analyze and they're like, shock. So patient advocacy can be, also a form of mediation. So I'm a certified mediator and arbitrator. How many of you have ever had a family dynamic around somebody who was sick, or drama started to arise as somebody in the family was getting older? There was a health issue that was advancing. How many of you have had to, there's drama that comes up. There's energy that comes up. Things are triggering people's history with that individual or family dynamics, or maybe it's the family member you don't really want to deal with, but now you guys are all together and now you've got to make some decisions. And wouldn't it be a lot easier to have somebody who was a mediator to help you have those conversations and just kind of coach everybody together? Let's be here for the sake of this person and to help coach you through these conversations. This is an invaluable resource that I don't know any other patient advocate in the entire country who offers family mediation. And that's something I do. I'm a certified mediator and arbitrator. Have your wishes. Yeah, right. Have your wishes early. Now, there's a big push to have healthcare proxies and advanced directives done actually as people are going off to college. As young people are going off to college, they turn 18. This is the time to have these conversations because often young males engage in high risk behavior. A lot of things can happen. Kids go away for college or they're going off into jobs. They, look, we have workplace injuries that happen. There's all kinds of things that may happen. Car accidents, very common with young people, right? And motor vehicle, MBAs, overdoses, all kinds of things that may alter somebody's life forever to the point where they are no longer able to express their wishes. So having a healthcare proxy who will be making those decisions for you if you're not able to, and having an advanced directive, what are your wishes if it comes down to that, is really important. So again, this has been a great live, you guys. I super appreciate you guys. Back to our Nurse Liz discussion, have these discussions early and often, make your wishes known, but put it in writing. Put it in writing, because a lot of times when somebody makes their wishes known, it's like that game of telephone, right? So when you make your wishes known, but you're telling, if I'm telling, let's say, child 1, child 2, child 3, child 4, or brother, sister, this 1, 2, 3, and they're hearing maybe something different, or maybe I have changed my mind over time and I haven't, brought everybody back together, then there could be, this is exactly why there are disputes about end of life care. And not everybody, this is another reason it's very important. And I've talked about this, I think, on Nurse Liz's live, and I'll talk about this more. I once had 3 wives show up and like 7 kids. And it was basically, I had to flip chart the whole family, and every state's different, right? Some states don't go to the next of kin to make decisions, like Wisconsin, I believe, does not. That's a very unique state. It could go to, of course, the current wife in some states, and then it may go to the eldest child. So the eldest child may be the child of a different person that's not the current spouse, or maybe they never were the spouse. So then now you get, eldest child and then current spouse, and maybe they don't even see eye to eye, right? Which is not uncommon. So there's a lot of factors that can come into play, especially if somebody has multiple children from different people, different individuals. There can be a lot of confusion about that. Send an email, have a Zoom. Yeah, have a Zoom call and get everybody on the same page. Look, we all can do Zoom, and email's great, but make sure that you do what is legally required in your state. And if it has to be notarized, notarize it. Not all states require notary. I'm in Virginia and they don't require notary. California does for advanced directives, and these documents are not portable. So if something happens to you and you're on vacation in another state, those documents are not necessarily, they're not legally recognized in each state, but you should carry them with you and carry copies with you. And these are really important things to have, you guys. So let me know in the comments if you're watching this video later, have you had these conversations with your family? Have your parents or anybody had them with you that's older? And it doesn't really even have to be an age thing, initiate those conversations with your parents. And a lot of people don't want to have those conversations. There's a lot of cultural taboo. My grandfather never wanted to have these conversations. And of course, it was a huge cluster at the end of his life, right? With his kids. So, people want to avoid and not have these conversations, but they are doing a disservice to their children. So if you're watching this video and you've stuck with me this whole time, I really appreciate it. Have the conversation with your family members, your spouse, your partner. And if there are people you don't want to make that decision who may be legally in line to make that decision, you need to make that known as well. Because I certainly, myself personally, don't want any of my family members that I'm related to by blood making any decisions about me. I've already designated who my healthcare proxies are. So it's very important that you do that. And if you're in a same-sex relationship, if you're not married, then it's very important that you do what is needed to make sure that you have some legal recognition, and go see a lawyer, get the forms filled out, go to the Pulse website. That's a great resource. We've got lots of information there if you just want to learn and download some forms, take a look at it. You can send the website to your family members, and then I'll have some information also more on my website. But Pulse has tons of stuff. It's already there, and it's all free and downloadable, and the videos are there. Thanks you guys so much. At minimum, it gives medical staff, right? Because we don't want to be the last thing we want that Adrienne wants with a nursing license is to have the wrong person make the decision about somebody's care that may be a decision about not resuscitating or not intubating. I made those decisions for my mom. I was the youngest, but I was also the one that was physically there, and there was no question about it. Now, that may not always be the case. If another one of my siblings had showed up and wanted something different, they could have superseded me. Now, again, it's important that people update their documents. Make sure that you're updating all your documents. You review them annually, minimally annually. So again, this is what a patient advocate will do. They're basically like a case manager, social worker, mediator, advocating for you, assessing your situation, making sure that you're also getting the best care, and making sure that you're having the care that you deserve, and that is the care that you're receiving appropriate for what you're being treated for. So again, we don't do medical advice, but I may ask a patient, well, has the doctor ordered this? Have you looked at, have they ruled this particular disease out? Right? We don't give medical advice. We don't tell people what to do. We don't give advice per se, but we guide people and coach people. So that is part of our services, but to ensure that you, the client, are getting the best care that you can possibly receive, and that there is no stone unturned in the care that you receive, aftercare, the treatment you receive. Some people deal with racism, discrimination in healthcare. That's another reason people get a patient advocate. And maybe they've already had a bad experience at a hospital. Maybe they're being told there's no other facility for them to go to, and there actually is. Scott will be, yeah, hey, thanks. Thanks, you guys. I super appreciate my guys supporting me. My YouTube brothers, Mr. Midwife and Scott, make sure you guys follow them. Appreciate it so much. Or Mr. Midwife, do you have a channel yet? We got to get you a channel. PO, yeah, Scott's going to just be all of our POAs. I'm going to designate Scott. All right, you guys, thanks so much. Have a great afternoon and have a great day and great week.